Good evening, everyone. How are you all? So welcome to First Aid AMC Clinical again. And I understand that you know that this is our first class of the free 2-week session, right? So I guess you guys are excited about all of these sessions that's coming up. And all the schedules are already given in your Facebook group. So I guess all of you know that already. So we also added another class just on random role play session, which will be taken by Dr. Cynthia. So I'll be there. I'll start the class also on 8th of February. And so that will be also one of the other class that we take regularly every week. So as I said initially, that normally we take classes, live classes like that every week, 3 times a day, 3 times a week. And it's mainly on Saturday, Sunday, and also on your Wednesday. But the 8th February class, we're just taking it as part of our another doctor schedule. But normally the classes are always on Saturday, Sunday, and Wednesday. Okay, so I guess that you guys will enjoy that as well. Now, tonight's session is mainly on the class that we have taken few days ago, which is your Psychiatry MSE. And I guess that you guys were in that class because this class is mainly focused on psychiatry mental status examination and also how to take a psychosocial history appropriately. And also we'll be mainly focusing on improving your approach towards a patient and also how you can communicate with the patient appropriately without sounding too much judgmental in the exam. And that's one of the first things that you need to learn when you are preparing for AMC Clinical. All right, so let's start with the role play. And remember one thing, that this is just a part of the psychiatry class, and psychiatry is not done. Psychiatry will be again done in our theory sessions, especially most likely after a few months, we also do a psychiatry session there are 3 or 4 more classes on other cases. So it doesn't mean that only MSE comes in exam. Also, there are some other cases which comes in exam frequently. So we'll discuss those, but not tonight. Tonight is mainly on MSE and also how to present MSE to the examiner, how to take a history. That will be the main focus. Okay, so we can start now. Who wants to do role play? Now, I do understand that most of you are beginner. Some of you just passed MCQ. So you can just give it a try. There is nothing wrong in your history taking or in your MSc presentation. If you just use the knowledge that you have learned in the last session, that should be fine. Okay, so there is nothing you need to think about because most of the people who are here, they are beginner. And some of you are already, you know the cases, already you have been preparing by yourself. That's also fine. You guys can come forward and the beginners can learn from you that how to take a history and how to present MSc. So that will be a blended learning, which is very important for any course, that you learn from your mentor, you learn from others. Everyone's approach is different and you take the best approach from these role play sessions. Okay, so there's a lot of candidate who wants to do. That's really good. Let's start with one by one. So I can see Dr. Nusrat Jahan, you want to do it. And I can see you are the first who wrote it. So I'll go with you first. And then Dr. Habiba and Dr. Shirin. Okay, so I'm going to unmute you, Dr. Nusrat Jahan.
Hello, doctor. Can you hear me?
Oh, you can unmute yourself. Yeah, I can hear you. Okay. Now I'm going to give you the case. The case is all about online format for the moment because we are doing mainly the online sessions at the moment. And also time to time in the course, you guys will get that face-to-face format as well. But tonight, let's do it as an online. Because that's the most of you will go for online exam this year also.
Yes.
Okay. And the time I'm going to give it to you is 7 minutes 30 seconds in the inside and 1 minute outside. But normally in the exam, you will get 2 minutes to read the case and prepare yourself in the head that what you want to do, and 8 minutes inside. But for the purpose of role play, always do it as a 1 minute outside and 7 minutes 30 seconds inside, so that you can manage your time better in the exam.
Oh. I'm not good at it, but I'll try. I'm just a beginner.
It's fine. Yeah. So that's really good and brave that you are doing role play. And that's all that I want.
Thank you.
Okay, so this is your case. Your 1 minute time just started. All right, doctor, your time just started. You can start.
Hello, John. This is Dr. Nusrat, one of the doctor here. It is very nice to meet you today. How are you feeling today? Are you okay?
I don't know, doctor. I just don't want to leave, doctor. This life has no meaning for me anymore.
Okay, I understand. It must be very distressing for you, and you must go through a very tough time. I understand. I'm really sorry to know about that. And you can tell me what making you really stressed. I want you to understand that you can be frank with me, and there is nothing that will make me judgmental about you. And there is nothing you need to be embarrassed about. I get to know a lot of patients during my consultation, and there is nothing to be feel judged or blamed or embarrassed about anything. I want you to know that I'm here to help you in every possible way, but I need you to know what's going on with you, or what's going on with you, and then I will be able to help you. I need you to understand the conversation we are going through is very confidential, and I'm not going to disclose it to anyone else unless it is harmful for you or others. So can you tell me how's your mood these days?
I don't know, doctor. I think like I should not leave anymore. And I feel like not leaving anymore. And I just killed one of my patients.
Okay, I understand. I'm very sorry to hear that, and it must be very difficult for you. How's your sleep? Do you have any difficulty?
Yeah, I can't sleep.
Okay. What is the problem? Can you tell me more?
Yeah, it's just like I keep thinking about what I have
Okay.
done with.
Okay, John, I understand. And how's your appetite, please?
I don't want to eat. I don't want to live anymore.
Okay. Have you lost your weight recently?
I don't know.
Okay. John, do you find it is difficult to concentrate on things?
What's the meaning of concentration? I killed my patient.
Okay, I understand. It must be very difficult. I'm very sorry to hear that. Do you think do you have any passing thoughts of harming yourself or others?
I don't want to kill anyone, doctor. I already killed one patient.
Okay, don't feel that. You are a good doctor. It was just an accident. Uh, uh, I think you are a good doctor. Please don't say that. Now I'm going to ask you some screening or sensitive questions that might seem quite strange to you. Is it all right?
Yeah.
Okay. Do you see, feel, or hear things that others do not?
I can hear them saying that I did malpractice.
Okay. Who are those? Your patients?
All the nurse, all the colleagues,
All the
all the time they just talk about me. I can hear
Okay.
them saying I'm
I understand, John. Do they tell you to do something?
no,
Okay. Okay, John. Do you think someone is trying to harm you or spying on you?
no,
Okay. And do you think you have a special power?
no,
Okay. And do you think someone is inserting or withdrawing thoughts from your mind?
no,
Do you think your thoughts are broadcasting to TV or radio?
no.
Do you think people are talking about you?
Yeah, they're talking about me. All the time they're just talking about me.
Okay. John, do you know where are you right now?
I'm in the hospital.
And do you know what's the date today?
I don't know, doctor.
Okay. Do you know who I am?
Yeah, you're a doctor.
Okay. Very good. Do you think you need some medical help?
No, I just don't need anything. I just want to kill myself.
Okay. Let us suppose that if there is a fire in this room, what would you do?
I'll just sit here.
Okay. So, John, can you tell me how's your home situation? Is there any stress?
Yeah. No, my wife is very good.
Okay. And do you do smoking or take any alcohol?
No,
Do you take any recreational drug?
no. Your 6 minutes is up.
Okay. Do you have enough support?
Yeah.
Okay. And do you have any past mental illness history or any history in the family?
No,
Okay.
no,
Did you had any head injury recently?
no,
Do you have any weather preference?
no, doctor.
Okay, thank you, John, for your information. I would just like to talk with my examiner, please. Dear examiner, I would like to present the mental state examiner of my patient, John, who is a emergency department nurse, and one of his patient has recently died due to meningococcemia, and um, he was attempting to take a pile of tablets. In terms of his appearance and behavior, he is well dressed, appropriate to the weather, well groomed, and he was not very cooperative, and he was not maintaining any eye contact throughout the conversation. He didn't have any abnormal body movement or posture. In terms of his speech, I think it was slow and monotonous, but there was no disorganized speech or any rapid pressure speech, and he was also taking more pauses in between most of the time. In terms of emotion, he says his mood is low, he thinks that it is not worth leaving the world. And I have also observed in affect that it is also congruent with the mood. In terms of perception, he did have an active auditory hallucination, but he didn't have any common hallucination or any tactile or visual hallucination. In terms of thought form, I think his thought form was linear, and there was no loosening of association or any flight of ideas. In terms of thought content, I think he was having a delusion of guilt, but there was no delusion, and also delusion of ideas of reference, but there was no delusion of grandiosity or no delusion of control. His insight was poor. And judgment was also poor, and he was not oriented to time, but he was oriented to place and person. In terms of risk, I think my patient is a high risk patient because he was having active hallucination, and I was maintaining a good rapport with him, and I think his history was reliable. Thank you, examiner.
Thank you. Your
Sorry,
time
I think
is
my
I
time
hope.
is up. Okay,
Yeah.
sorry.
Okay, no, that's fine because I actually let you to finish the case. That's
Thank you.
okay. Now, but Dr. Nusrat, you did really good. I would say that if you are a beginner and you're doing like this moment, you will be so good in after 5 months. Okay, so
Thank
you
you.
heard a lot of things that we discussed last time, and the way you started, it was really nice. Just don't say I understand what you are feeling. That's
Okay.
one that I would always say to all of you, not to use this line, because most of the time we tend to say that I understand that what you are feeling, but normally we don't. So that's one of the things that I usually advise everyone to not to use this particular line. You just say that I'm here to help you. Please don't think that like you are alone here. So anything that you are saying, that's totally fine, but just don't say about that I understand that how you're feeling at the moment.
Okay, doctor. Can I
So
say it must be very difficult for you?
yeah. So anything in that way is fine. Just don't say I understand. That's all that you need to correct in the initial approach. But other that you used, that was all good. And another would be like the starting was really good, I would say. And
Thank you.
also in your history, I don't think that you have missed any particular point. You asked all the important stuff that's needed in here. And one of the things that we can do, especially if there is a task of suicidal risk assessment, like third task that you can see. Now, you do understand that the MSc presentation also has a risk assessment, right? The 3R that we do at the end.
Yes,
So
doctor.
actually saying the number 3 task by this R in your MSc presentation. When you're doing the risk assessment or saying that my patient is high risk, some of the other things we need to add, especially if there is a task like this. Otherwise, you can just say that, yes, my patient is a high risk because of active hallucination and delusion. So what are the things that we need to add in risk assessment? There is some criteria for tailing this risk assessment to the examiner. We will go through that in the next few cases. But just for you, I would like to say that in case of risk assessment, especially if there is a task specifically for that, we need to say a couple of points. Like one of the point would be patient is having active hallucination, active delusion that you said. Patient doesn't have any insight, lack of judgment. Patient is an ED nurse, so he has access to medications. So it also puts him in high risk to use those medications for suicide or harming himself. So that's one of the things. You could also ask about like any previous history of suicide. And at the moment, does he have any active plan for suicide? When there is a risk assessment task, we need to go in a little bit of detail about the suicide thoughts. So a couple of questions. The first question is, do you have any passing thoughts of harming yourself or others? Yes, doctor. Then the next question is this the first time you are having this kind of thought? Did you ever tried it before? Any previous suicide attempts did you have? Do you have any active plan at the moment? Do you have access to any particular weapon? Okay. So these are a couple of questions we would ask just in here. But if it is not a risk assessment is a task, then you don't need to go in this much detail because you will not have that much time at that case. But for this particular task, because there will be a marking in here, you have to just ask that questions just to get a pass mark in this particular task. All right. So that's the only one thing. Other than that, you did all good in the history. Then MSE presentation, you did all the important things. I don't think you have missed anything. So in the perception, this patient was having auditory hallucination that you said, and thought form was linear. Thought content. Now, thought content, there are two thought content in here. One is delusion of guilt that you said, because patient thinks that yes, he is guilty of murdering or guilty of dying this or like killing this patient. So there was a delusion of guilt and there was a delusion of reference, because when you asked that, do you think people are talking about you? I said, yes, people are talking about me. So that's delusion of reference. So you did say that, that's very nice. Insight judgment was impaired, cognition impaired in terms of time, as you said, and others are also good. So I think like you did really, really good. Just in the risk assessment, we need to add those particular points.
Thank you, doctor.
Thank you.
Thank you.
Very good question, Dr. Shumi, that yes, patient at the first patient told that I don't want to leave. So, but just because we just want to confirm what he actually wants, we know that this patient is suicidal, but we need to go in a little bit of detail about it. So do you have any, or you can say in terms of saying that, do you have any thinking of harming yourself or others? You can also say, do you think the life is worth living? If they say that no, then you can ask the next question. Are you having any active thoughts of harming yourself or others? That question is fine, because this is mainly focusing on risk assessment, this task. We have to go in detail about this particular thing.
Japur, can I ask a question?
Yeah, go
on. In online exam, can we have a piece of paper to write down aseptic J3R?
Yeah. So you will have pen and paper in front of you. You can't write anything in the 2-minute outside, but when your case starts, that 8-minute time, you can write anything that you want.
Okay, in online too?
Yeah.
Thank you.
Now, Dr. Tenjin, yes, you can ask open-ended question, but the problem is that this particular case, we can't ask any open-ended question to the patient. Why? Because this patient is suicidal. What we are going to ask, can you tell me a little bit more about what's happening? Now, that's also okay to ask in my case, but most of the time, the suicidal depressed patient, they don't answer your open-ended question. But you should give it a try at least once. That's fine. Like you can just say that all the things that you start with, then after the confidentiality statement, you can say, would you please tell me that, is there anything that I should know? Or would you please tell me what's going on? Or would you please tell me why, like, is there any particular reason that you wanted to take a pile of tablets? So that open-ended question you can ask, but most of the time this patient will be so depressed and even crying in front of you, even will not answer your questions properly. You will end up asking these closed questions eventually, according to the format. But you should not ask that how I can help you. This patient does not want your help. That's the problem. Okay. But you can ask that, you can say that I got to know from my notes that your wife saw that you were able to take a pile of tablets. I'm really sorry to know about that. I can't even imagine that what you were thinking, which led you to take this pile of tablets. Would you please Like then you can say those words that please don't worry, I'm here to help you. There is nothing that will make you feel judgmental to me. You don't need to feel anything, like you don't need to feel embarrassed about anything. You don't need to feel blamed about anything. So all these things you can say, and then you can say, would you please tell me a little bit more about it? What exactly happened that you wanted to take a pile of tablets today? So that's fine, but don't say that how I can help you. They will say, I don't need your help. In here, Dr. Delaney, the task is important always. Always remember that if your task is MSE presentation, you don't need to diagnose the patient. To diagnose this patient with depression, you would need the MSE criteria for depression. But for this case, they haven't asked you any diagnosis. So you don't need to ask the full depression question. You are asking mood, sleep, appetite. You also asked concentration. You asked about suicidal thoughts. So you already asked a lot of questions about depression. And I think like Dr. Nusrat has asked all the insight caps question already. So if you're asking at least 4 or 5 depression questions in this case, that's fine. Because mainly in here, you're trying to find out the, excuse me guys, just a second. Sorry. So in this case, mainly you are trying to find out the MSE presentation, that means the aseptic J3R, okay? Because you will not have that much time to diagnose this patient. If you want to ask all the question of MSICH caps, you will not be able to finish this case. So cutting the history according to the task is important for exam. If you are going fast, if patient is answering all your questions spontaneously without giving you any trouble, then yes, you try to ask more and more questions. But in this case, you will not be able to get answer very quickly from the patient. They will be very slow. So you will not have that time. So you need to understand what is important to pass this particular station. For this station, you take a history in terms of MSE presentation. But as the risk assessment is a task, you have to also ask the heads, SADMA. That also, I think, Dr. Nusrat has asked. So she asked about home situation. The work situation also should be asked. And then SADMA, so alcohol, smoking, recreational drugs. That's all the history that you need to ask. No, and Dr. Fernando, in online exam, there will be video. So you will be on a video. You can also see the patient. So they will not play a video of the patient. The patient will be in front of you on a video. So you will be able to see whatever they are doing. So that should be fine at that time, that the appearance, behavior, you can actually comment on that based on that. Yeah, you can always reassure him that it is never ever your fault. I'm sure that you have done everything that you could. Okay, so always say something like that, like say that, John, I do understand that, or you can say, John, I got to know from the notes that recently one of the patients died because of meningococemia. And I do understand that you are blaming yourself for that. But I want you to understand, or I want you to know that it is not your fault. There is nothing wrong that you have done. And I'm sure that you have done everything that you could. Always you can reassure them. It's very good that you do it. Yeah. So it comes with the app. When the patient is in front of you, if the patient's crying in front of you, you should give some pause, offer a glass of water, offer tissue. So even in online exam, you can always say that, John, I'm sorry that you had to go through this. I can't even imagine myself in your place. I know from the notes that one of the patients recently died of meningococemia. And I'm sure that you have done everything that was in your capacity. But sometimes these things, we don't have our hand on these things. And sometimes even though we do everything in our capacity, still these things happen. And that's not your fault. So you can always say those sort of things. It totally depends on how you want to reassure the patient. Everyone has their own perspective on reassurance. So always use some of those things. And I'm sure that when you see the patient on video and patient is crying in front of you, you will end up calming the patient, reassuring the patient. Okay, that's how things happen in as a natural part of being a doctor, right? So you just need to think in that time that this is not an exam that I need to pass. This is a real patient in front of me who need my help. When you can start thinking in that way, you already are going to pass the exam. Like in 50% case, you are already there to pass the exam when you start thinking in that way. Most of the first time candidate, they just go there to pass the exam, and they think that, well, I have a limited time, I need to finish the task. So they just focus on that particular part. And that's why AMC can't pass someone if they are just showing that they are here to pass the exam, not to care for the patient. So you just need to build up that part in your head that, will it may be exam, but I can't show it to my examiner that I'm here to just pass the exam. Okay, these are real patients, and you just need to think in that way. All right, so lots of bubbling. Let's do another case. I think Dr. Habiba was next. You can unmute yourself.
Hello, doctor.
Hi, doctor. Okay, just give me 1 minute. I'll give you the case.
Sure.
Okay, so this is your case. Your 1 minute time just started. All right, so your time just started. You can start.
Hello, I'm Dr. Habiba, one of the doctors of this general practice. How would
Yeah,
you like
the
me to
devils
assist
are
you?
after me. Those devils are after me and these angels. Yeah, I can see those devils.
Okay, Mila, I can see that you're really stressed, Mila. Please don't worry. I'm here to help you. I'll do everything possible. Okay, Mila. So, Mila, thank you very much for coming here today. Mila, I'd like to ask you a few questions so that I can assess your condition properly and I can help you. Is that okay, Mila?
No one
Mila,
can help me.
are you okay?
No one. The devils are there.
Mila, I can assure you that I am here to help you and I'll do everything possible. You can trust me, Mila. Okay. And Mila, I can
I
see
don't
that
trust
recently you
anyone.
have delivered a baby. So how are you coping with it, Mila?
Yeah. Oh, where is my baby? Where is my baby?
Mila, your baby is in safe hand. Okay, please don't worry about your baby. Okay, so Mila, here I am going to ask you a few questions. I assure you that whatever we are going to discuss today to remain confidential. So feel free to share. You don't feel embarrassed or judged, Mila. Is that okay, Mila? Mila, how are you feeling these days?
I don't know.
Mila.
Those devils are after his angels and me.
Okay, I see. So Mila, how is your sleep these days?
I don't know.
Mila?
I can't. I can see the devils are coming after me.
Mila, I'm here to help you, Mila. Please try to answer my question so that I can help you. I will do my best.
No one.
So Mila, how
No
is
one
your
can help me.
appetite? Okay. So Mila, do you still enjoy the thing that you used to enjoy before? Okay, Mila.
What is going on?
Yeah, can you see the devil?
Yeah, I can see. I can see that they're just coming after me.
Okay, yeah. Does the devil tell you anything, Mila?
No, they're just looking for me.
Okay,
I'm hiding.
can you feel the devil?
No,
No, okay. And do you think that someone is trying to harm you or the devil is trying to harm you?
I don't know, but they're just coming after me.
Okay. Do you think someone is controlling you
No,
or do you think someone is spying you? Mila,
I don't
do you
know.
think you have some special power?
No,
Okay, Mila, do you feel guilty for any reason?
no.
Okay, Mila, try to relax, Mila. I'm here to help you and I will do everything possible. Okay, just trust me. Okay, Mila. And Mila, see, now under certain circumstances, people might think that their life is not worth living. Anything like that happens to you. Uh, okay, Mila, have you
If no, the
tried
death is only
ever?
answer.
Yeah, Mila, have you tried to harm yourself or other people?
No, just the death is the only answer that I have now. There is no one who can save me.
Okay, Mila, please believe me. I'm here to help you, Mila. Okay, so Mila, so do you think you need some professional help right now?
No, I
Uh,
don't know. There is no one
okay.
who can help me.
Yeah, I am here to help you, Mila.
They're
So
coming
Mila,
after. I
let's
can see
suppose
them.
if this, Mila, let's suppose if this room set on fire, what will you do?
I don't know what
Do
I can't do. They're just coming after me, doctor. I can't do
yeah,
anything.
no, I am assuring you that Mila, I'm here to help you. Please believe me, okay? I will try my best, and I will try my best to help you to help your baby, okay? So Mila, um, and do you know where you are right now and who I am?
Yeah, I'm in the
Do
hospital. Anyone, doctor?
yeah, perfect. And do you know what the time now?
No,
Okay, Mila, do you feel warm when other people feels, I mean, cold? Any
I
history of
don't
head
know.
injury recently? Do you feel feverish,
No,
Mila? No. Okay, Mila. Do you have any
no,
known medical condition, surgical condition that I should be aware of?
no,
Okay, Mila. Have you ever been diagnosed with any mental health illness or any family history of any mental health illness?
no,
Okay, Mila. Do you do any recreational drug? I'm sorry to ask.
no.
Okay, are you on
6
any
minutes up.
medication right now for any kind of illness? Okay. Okay. Thank you, Mila, for all of the information. Please excuse me for a moment. I would like to talk with my examiner. Well, examiner, now I'd like to present the mental state examination of Mila, who is 35 years old lady, currently postpartum 3 weeks, and she brought here by her husband. She's not coping well. So, regarding appearance, the patient is dressed appropriate to the weather, and there is no abnormal body posture, no abnormal body movement. The patient was not maintaining eye contact, and there was intermittent eye contact maintaining, and the patient was not that much cooperative. And regarding the speech, sometimes it is high, sometimes it is low, and and regarding emotion, the patient didn't answer to my question. The effect I have observed, I can see that the patient is restless, and and Mila has having auditory hallucination and also visual hallucination, but there is no common hallucination, and she didn't have any tactile hallucination as well. And regarding thought form, there was loosening of association, and the thought content, there was no delusion of there is no persecutory delusion, no delusion of reference, no, and no, there is no delusion of grandiosity, and then regarding insight is impaired, and patient is oriented to time, place, and person, and the judgment is I couldn't assess the judgment. She didn't answer my question. Okay, and okay, the patient is of high risk because she is having active hallucination.
No.
Okay, yeah.
Okay, you can continue.
Okay, so examiner, my diagnosis is postpartum psychosis, as the patient is having active hallucination, and other differentials, it could be due to schizophrenia, but here the symptoms is only for 3 weeks, and it could be due to acute mania, but unlikely according to the history. It could be due to acute psychosis, or it could be due to drug-induced psychosis, but the patient is not using any recreational drug. It could be some organic cause like hyperthyroidism, but unlikely. We didn't give any history like that. Okay, thank you,
All
examiner.
right. Thank you, Dr. Habiba. Thank you so much. It was really nice, I would say. And the approach is good. But one of the things I would say that, like, one thing that you could add in here is that, like, when I was saying, or the patient was saying that David sir after me, you kept saying that I'm here to help you. Try to use a little bit more variations of reassurance. Like, I would also add, like, Mila, please don't worry. I'm here to help you. And also, I want you to know that you are safe here. There are lots of people in here. There are guards here. If the Davis are after you, we are going to protect you. There is nothing you need to worry about. And you are in a very safe hand right now. I want you to know that you are not alone. And I will not keep you alone in this room. I'll be here staying with you as long as you feel safe. See that this is the way you make the patient feeling safe, right? So other than using just one particular thing, doing some variation makes the case interesting and makes the examiner feeling a little bit of different to you, and eventually you pass the station. So those are the things you just need to think in your head that time, that, well, let's talk something else. There is nothing wrong with reassurance. That's the thing. You can use anything that comes into your mind as long as it is not like, it's not judgmental.
Okay.
Yeah. Now, Anna, couple of things that we could do in here is that, let's say let's talk about the history a little bit. So you asked about when, in this case, when you get to know that patient's first thing that like devils are after me and his angels, that's the first starting. You already know that what's going on with this patient. You know that this patient having psychosis, right? At that time, don't stick to the format all the time. Come around, start with the psychotic question first. So you can start saying that, please don't worry, and reassure them, and then ask that how long you are feeling this way. The duration is very important to make a diagnosis. So always try to ask the duration of these symptoms in every case. So ask that how long you're feeling this way. Do you think it's getting worse day by day? Okay, and then you can ask that, well, I can see that you are worried about the devils. Can you see them? How many are they? Are they giving you any specific comments? Are you hearing them as well? Okay, so obviously, like, no one would feel the devil, right? So we don't need to ask those questions, but in here, most likely we need to ask about those specific questions, like, can you see, can you hear? So now you are asking about hallucination question. Once you are done with the hallucination, you can go to the delusion question, because these are interconnected. So ask all the delusional question. In this particular case, was there any delusion positive, guys?
Persecutory delusion.
Yes, that's right. So that was a delusion of persecution, because I say that devils are coming after me. Okay. Now, when you ask that, do you think someone is trying to harm you or is spying on you? If I say, I don't know, devils are coming after me, I would not answer exactly that, yes, I think like someone is harming me. I would give you the like answer in some other way, but you just need to interpret that. Same happens in the exam also. If you ask me that, do you think someone is trying to harm you or is spying on you? If my answer is, yes, the devils are after me, what does it mean? I'm trying to give you that answer, yes, I have the delusion of persecution. You just need to interpret that in the exam. So you, in this case, when you know that it's a psychotic case, you should ask all the delusional questions. So follow the RCGGP, because you don't know which one will be given in the exam. And if you miss that, you fail the MSE. So ask about control, reference, ask about guilt, grandiosity. So all the thought insertion, broadcasting, try to ask those questions more, because this is the most likely the positive findings in your exam. Mood, sleep, appetite, you will not get anything in this case, because this is not a depression case. But as a part of your MSc presentation, you just need to ask it. So you will ask it at the end. So after you finish your hallucination delusion question, then one by one you ask mood, sleep, appetite, suicidal thought, homicidal thoughts, and eventually you finish the case. All right. So that's how you need to just change your approach depending on what type of cases are coming. You will know immediately when you start your case that is it a psychotic case, it's a mania, it's a depression, it's a OCD. You know exactly. You will understand by the look of the patient. Okay, so that's one thing. I think like that's the only history thing that you can just wrap it up. MSc, you did good. Now, one of the other thing I would say that in case, in the appearance and behavior part, try to add that patient was responding to some unseen stimuli, or patient was responding to some internal stimuli. So that's because if a patient having hallucination, delusion, they used to respond to some unseen stimuli. Like you will get it in the exam also. If you patient is not maintaining contact, looking here and there in the room, looking at the ceiling, that time you just add this, that my patient was responding to some unseen stimuli. So those things, appearance and behavior, you just need to add it by the look of the patient when you can see the patient on the video. Speech, you did say right. So speech was sometimes normal, sometimes loud. That's fine, but there was not too much disorganized speech, I would say. Then we have emotion. Patient did not comment on the mood, but you can say the affect that you have observed that was disturbed. Perception, there was auditory and visual hallucination. Thought form, in here, if you can understand a patient, then the thought form is fine. If you can't understand anything what the patient is saying, then you can say that patient having loosening of association. So in this case, you're understanding the patient. You can say thought form was linear, but sometimes it was a little bit of disturbed. That you can say. Then thought content, there was deletion of persecution, others were not there. Inside was impaired, or judgment, actually you did not get an answer, so that's fine. If you don't get an appropriate answer, you can say that patient did not answer my question. But you can always say that, but I think my history that patient judgment is impaired because of this. And cognition was okay, but he was not actually oriented to the time, but place and person was fine. The patient is a high-risk patient. You were not able to maintain a very good rapport with the patient. The patient was disturbed. It's not your fault. And you want to take another history from someone, maybe from the husband, you want to take a collateral history. So that will be your MSE presentation. Diagnosis was right. It's a postpartum psychosis. We would not say postpartum depression with active psychosis as the diagnosis. There is a specific diagnosis for these sort of things. We say postpartum psychosis. That's the diagnosis. What are the differential diagnosis? Yes, there is some noise I can see. Dr. Habiba, I will just mute you for the moment. Sorry for that. So in this case, you can say postpartum depression is one of the differential diagnoses, and postpartum blues will be another differential diagnosis. Postpartum adjustment disorder will be another. We already talked about depression. Psychosis is the diagnosis. You can always say mania or bipolar disorder as one of the DD. Substance abuse or drug-induced psychosis can be a DD, or even schizophrenia, brief psychoactive disorder, schizophreniform disorder. All of it can be in your differential diagnosis, as long as you are saying that why you think that it is unlikely. See the task in here, why your differentials are unlikely. That means you need to say to the examiner that how did you rule out your other differential diagnosis. So you have to have a good idea about these things. So let's say there is some feedback given in the software about these cases also. When you actually entered into the course, you get access to the software, and you can always access any of these notes from there. Now, postnatal blues, it's a very common problem which occurs first 2 weeks after childbirth. Now, this patient is having it for 3 weeks, or it's started after 3 weeks, right? So we can't say that it's a postnatal blue. And also postnatal blue patient doesn't have hallucination or delusion. They only have like feeling depressed, mood swings, irritability, feeling very inadequate or tiredness, and their sleep gets disturbed. So that's postnatal blues. Adjustment disorder occurs in the first 6 months. The symptoms are similar to the postpartum blues. Mainly trouble is patient feels anxious about taking care of the baby. That's the only feature, nothing else. Depression, patient usually can present to you at any time in the first 6 months after a baby, and they will have all the major depressive disorder features. But this patient did not have anything like that. Okay. So this is how you can say one by one that this is why it's not my differential diagnosis. And also you can say that it could be mania or bipolar disorder, but my patient was not having very elevated mood. He was not having any insomnia, no flight of ideas or rapid pressure speech. So it's very unlikely. So always say that why do you think that this is not your diagnosis? So how you are ruling out your DD, you should always explain it. And it's even better, even if they don't ask it in the history or in your task, always when diagnosis and DD is a task, always add it that, well, it could be due to postpartum depression, but my patient does not have low mood, my patient does not have sleeping difficulty, not any active suicidal thoughts, and no other features of depression. So I'm not suspecting it as a postnatal depression. So always say in that way that how did you rule out your differentials? Okay, I can see some of your questions are here. Doctors, okay, always guys, like when you are joining the sessions, try to write your own name so that I don't end up asking you, like Dr. Strange told me that this is this, okay, or Dr. iPhone told these things. So write your own name so that I can address you properly. So Dr. Strange told that patient was telling devil is after me. Can we tell that why do you think devil is after you? You can say that, but normally you will not end up getting any appropriate answer. So it's not very important to ask it. The why is not so important in here. But since when you're having this thought, or that's important because that will help us. And yes, it's very important to ask about the baby. She asked it that, like, how's your baby or how you're coping up with it. So it's a good idea always to say that, let me congratulate you on your baby. You must be so excited about it. Can I know, like, can I know your baby's name? So then you know it's a he or she. Then you can say how she is doing. Okay, and how are you coping up with this situation? That's always a good idea to address a little bit of questions about the baby is always important when you know that this is a postpartum case. Yes, Dr. Namia, delusion of persecution was there. And RCGGP means R for reference, C for control, D for guilt, another G for grandiosity, and another P for persecution or paranoid delusion. Yes, Dr. Javed, you can do it, but for a patient who is having active psychosis, the EPS will not be so much important. And also it's not important for this particular case because it's a part of management. The Edinburgh postnatal depression, that is scale that we use, EPDS, it's usually important for a postnatal depression or those sort of cases. Psychotic patient will not answer you correctly. All good. So any question with this case, guys? All right, now who wants to do the role play after that? We'll do a video MSE. I think some of you were there initially when I asked, so I will just follow that for the moment. So Dr. Shirin Akhtar, and then there was Arifa Sultana. Dr. Shirin or Dr. Arifat, are you guys still want to do it? Okay, I'm going to going to unmute you. Sorry, guys. I know that all of you want to do role play, but maybe will not be able to do it with everyone. But one by one, throughout the course, you will get to do it. Okay. So we always ask you, the new candidates, to do the role play. Always in every role play class, we ask the new people to do the role play with us. So eventually, all of you will get to do role play. There is nothing wrong with that. So I'm going to unmute Dr. Shirin.
Yes, doctor.
All right. So I'm going to give you a video MSE. Now the video MSE, it's usually in the exam, they show you a video for 4 to 5 minutes, and then they just ask you to present the MSE to the examiner. It's easy because you don't need to ask any question. You just hear the conversation between the patient and the doctor. You can note your finding, usually in the 4 minutes that they give you, and then you can present your MSE based on that. It's more easier than any of the cases that comes in exam.
Sorry,
So
doctor, I'm
let's
not
do
very
it.
good at it. I will try.
Yeah, that's okay. Now I'm going to show you, this is the question. Now, because this question will not help you too much, what I will do, we'll start the case anyway. So you can give it a read. And when you are done, just let me know. I'll start the video.
Okay, doctor.
Okay. Now, when I start the video, I will stop it at a certain point, and then I will ask you to present MSE. The MSE presentation will be for 2 minutes. Okay.
Okay, doctor.
Hello, Robert Smith.
Yeah.
Thank you for coming to see me today. I'm Dr. Stanley. I'm one of the doctors that works here. Obviously, anything that we say is confidential between us and the team that I work with, and your GP who's asked me to see you.
Okay.
I hear there've been some problems with your housing. Do you want to tell me a little bit about them?
Yeah, I've had all sorts of problems. I mean, where do you want me to start? My neighbours, police, people spying on me in my street. None of them will admit to it, but my neighbours, it's mainly them at number 9, but I've seen them talking to the ones at number 6 and across the road as well.
So when did things start to go wrong?
I don't know. I mean, you'd have to ask them. Well, like when they started properly, like deciding that they wanted me out of the street. I think it was a few months ago. Months. It's been going on for months.
What makes you think they want you out of the street?
Well, it's the harassment. It's the spying on me, putting bugs in my house, in my phone. And that at first they thought I couldn't hear it, but now they know that I know that they're there. Saying things about me through the window. Talking about what I'm doing. I know they're doing it. Whenever I leave my front door, woman at number 7, she's always there. She's clocking where I'm going and what I'm doing.
Why do you think they're doing that?
Well, I don't know. They just. I think they want me out.
Mm-hmm.
I think they're testing me, and they're trying to find out how far they can push me. Basically, it's all part of some test. I don't know why. I don't know what for. You'd have to ask them. That's what I've said to the police time and time again. I've said to them, why are you asking me these questions? Why don't you just talk to them?
You said that your phone was clicking. What was that about?
A landline.
Your landline?
Yep. Somebody rings me or I ring somebody, between 7 and 10 seconds in, I hear click, click, click. Click, click, click every time.
Any other explanation for that?
I don't know. What else? Well, it could be, but every single time, and then they're talking to me, and then they know what I've been saying down the phone. You know.
How are they talking? Where are they talking to you?
Well, I can hear them next door. Oh, he's on the phone again. Oh, he's reading that book again. You know, I can hear them saying it. And they know that I can hear them, and that's why they're doing it.
Okay, so just to summarise at this point, your phone's, something's happening to your telephone. You can hear your neighbours talking about what
Yep.
you're doing, making a commentary on your actions
Every day.
every day, and you feel that there's some sort of reason for all their actions doing this. Any other things that you've got problems with?
Following me down the street. People following me when I'm going to the shop. You know, it's happening more and more. It's happening more and more. I mean, I've tried to explain to my friends about it. They get really agitated. They think I'm off my rocker, but they don't see it. You know, they're not living with it every day.
Okay.
You know.
So your friends are worried as well?
Yeah.
So
Well, worried, or I mean, I don't think they're on it. I don't think, but they know a lot about what's been going. I don't know. Maybe the police have been talking to them or something, or maybe my neighbours have been talking to them. I don't know. Again, you know, you'd have to ask them. But you know, it's hard to know. It's hard to know who to talk to, because they all, you know,
So
they're all involved.
So this started happening a few months ago. Has it had any other effects on your life,
Well, yeah.
such as?
Can't really go out. Well, I can, but I know what's going to happen if I do. So I'm just trying to stay low key. You know, I'm trying to stay out of people's way. You know, I've hardly slept. I've hardly slept for the last, I don't know. I can't remember the last time I got more than 4 or 5 hours sleep.
So what disturbs your sleep?
I don't sleep until. I don't tend to go to sleep until after 2, 3. Well, I'm sure that they've turned everything off.
Right, okay.
You know, downstairs, and just can't. You know, I'm worried about it.
Any problems watching the telly, listening to the radio?
Oh yeah. They're using the TV as well. They're using all. They've got all this technology, obviously. I mean, I know there's all these smartphones and whatever now. You know, all they need is one of them, and they can just. But yeah, TV. You know, they've got the local news. If ever I watch that, you know, there's always some little comment. There's always something they say in there at the end about what's been going on. You know, pretty much every time I turn the TV on now.
Okay.
I mean, it's it's all just the cable, isn't it? So they could, for all I know, they've just plugged it into that.
What do you mean the cable?
The cable TV, you know, it runs down the street. You know, everybody's got access to it if they know what they're doing. You know.
So obviously, this is all very distressing. All the different things that are happening. Can I take you back a little bit and just find out a bit more about you? I think your doctor said you're age 29.
Yeah, 29.
Tell me a bit about where you were born, your upbringing.
All right, so that was the case. Now you have 2 minutes to present the MSE. And normally you don't get any time to prepare yourself in the head. Okay, so you just start your presentation immediately after the video is done. So your 2 minutes started. When your 2 minutes is running, then the time will be up. You should start it.
I should start it. Okay. Okay. Hello, dear examiner. I want to present the MSE mental state examination of my patient Smith, who is 29 years old. In term of appearance, his dress is appropriate with the weather. He is well groomed. He is cooperative with doctor. He is maintaining eye contact intermittently. There is no abnormal body movement or posture is present. In terms of his speech, it's understandable, and there's some pressured speech present, and And this is a pressured speech present, and there's no other slow monotonous speech. And according to emotion, his mood is not asked here, not assessed here, and the effect I observed is congruent with his mood. And in terms of perception, he has auditory hallucination. He has also, as he is hearing the neighbors talking about him, he has he has some tactile hallucination. He feels bugs in his hand, and he also has some visual hallucinations also, because he can see people are looking at him. And according to, in terms of thought form, his thought form is there is some loosening of association present. And in term of thought content, he has a delusion of persecution, because he thinks people are spying him, people trying to harm him. And he also have people following him. People are talking about him. He has some delusion of reference. He thinks people are talking about him. He have also thought broadcasting delusion of thought broadcasting, because he thinks people there's a commentary in TV about him. And according to his insight, it's not assessed. In terms of cognition, it's not assessed. I cannot comment on it. And in case of judgment, it's not assessed also. Doctor can maintain a good rapport with the patient, and his history is not reliable. It need to be assessed collateral histories also. And according to risk assessment, patient is in a high risk because he had active hallucinations and active delusion. And
Time up. Okay.
yeah,
So
thank you, examiner.
up about a minute ago. So in this case, Dr. Shirin, you did good, I would say, but because this case is all about how good you can present the MSE, because that's the only task, right?
Okay.
So
Yes.
they usually will not pass you if you miss a single point in this case. They're very picky about it. So you actually said all the important things. You haven't missed any particular point, which is really important. Now, a couple of things you can say that in the appearance and behavior, that first always start. Well, dear examiner, I'm going to present the mental status examination of a patient who was brought to, or you can actually use whatever written in here. Like, I'm going to present mental status examination of a patient who came with recent change in behavior with a past history of schizophreniform illness. All right, so always start with the introduction, and then you can say one by one. In terms of appearance and behavior, patient was dressed appropriately to the weather, well groomed, maintaining eye contact intermittently, but he seems quite frustrated and irritable or restless time to time. So that's one of the behavior you are talking about. And also you can say that he was having a stooped posture all the time. You say that there was no abnormal posture, but this patient was actually sitting in a stooped posture, which is a leaning forward posture. So that you should add in here, that because throughout the conversation, he was keeping that posture. So that's one thing. And then you go for his speech. His speech was mostly normal in tone, rate, and volume, but sometimes it was rapid or pressured, you can say. And after that, your emotion, always say emotion. In terms of emotion, my patient's mood was not assessed, but the affect that I have observed was disturbed. This patient affect is disturbed, you can see always. And perception, you say that this patient having auditory hallucination, visual and tactile. I would not say this patient having visual or tactile hallucination. Auditory is fine. It's very unlikely that it will be a visual hallucination, because throughout the conversation, he did not actually say that he can see something unusual, or they haven't asked it appropriately also, that can you see the neighbors or not. Now, I would just keep it as an auditory hallucination, because most of the time he's saying that I I keep hearing them commenting on me, talking about me. So mainly auditory hallucination will be appropriate because neighbors are there. Okay, like neighbors are not kind of visual hallucination for them. There is someone with him. Okay, so that's part like if I say that devils are after me, that becomes a visual hallucination. But if I say that, well, this maybe in the history you will find out he's living with some other roommates, and also there are neighbors, obviously. Now that's not a hallucination, I would say. And I'm not sure that if he said anything about the tactile hallucination or not.
He
So
said something like bugs in his hand. I think it's tactile.
yeah, okay. I may miss that, but I can't remember that if he said anything about bugs in the hand. Maybe they said that maybe he said bugs in the telephone or anything in that area. Yeah, bugs in mobile. That was the thing. Now, if he says bugs in mobile, that's not a tactile hallucination. Okay. So thing will be in here is the auditory hallucination. Then in terms of thought form, I would not say loosening of association in here. What is loosening of association, guys? You guys, all of you are having a little bit of trouble with that part. The loosening of association means that these are extreme psychotic patients. I have seen some patients like that in my career. Like, I don't even understand what they're trying to say. They're just keep talking and talking, and there is no way you can understand anything. You can't make a meaning out of their conversation. That becomes a loosening of association. In exam, you will never ever get someone with a loosening of association because they need to give you answer. Otherwise, it will not be an exam, right? So if you understand what patient is saying and patient is answering your questions, that patient has appropriate form. Okay, you can say disturbed sometimes if it is really a lot of unnecessary talking. You can say disturbed, but don't say loosening of association. And after that, you have your thought content. This patient was having deletion of persecution. You said that, very good. Deletion of reference and thought broadcasting. You don't need to say delusion of thought broadcasting, just thought broadcasting is fine. And after that, what else we have? Now you can actually make sure that you don't waste too much time by saying like all the things which was not assessed. You can say insight, judgment, and cognition was not assessed. Okay, rather than saying one by one, you can say three things all together and you can save about 10 seconds in that way. Okay, so always like think in that way that how you can save your time in the exam. And obviously the 3 are you said correctly, like obviously this patient having high risk, the doctor was able to maintain a good rapport with the patient, but the history is not reliable. So it would be a good idea to take a collateral history from his friends or the neighbors.
Okay, doctor.
Okay, you did good. So don't worry. I think like you're doing really great, but we just need like when you practice a lot about these things, it will become so easy. There are a lot of videos like this in the YouTube. Just go through this one by one and you just listen to it, give yourself a time and then just practice again. All of you. Okay.
Thank you, doctor.
Thank you. All right, guys. Any questions so far? That's fine, Dr. Arifa. Who was next to Arifa? Was next to Arifa? Anyone? So let's see. Dr. Tenjin? And Dr. Jahidul, you're here? Dr. Jahidul, Dr. Reham, any of you guys want to do? Yeah, okay. So let's start with Dr. Jahidul.
Hello, doctor.
Hi, doctor. All right, so you are ready?
Yeah.
Just give me a minute.
So I'm a beginner, so let me try.
I know, that's fine. Don't worry. All right, so this is your case. You have got 1 minute and then we will start. All right, so this patient name is Sarah. You can start.
Good morning. Good morning, Sarah. I'm Dr. Zahid. I'm working in this jeep station. I'm here today to help you. So far, I have heard that.
Oh, doctor, there is nothing wrong with me. I'm just totally fine. I'm feeling so good at the moment. It's just
Okay.
my counselor is so worried about me. There is nothing wrong with me. You can just leave me alone and I'll be just going. It's just a counselor. If you just write me something that I'm okay, I'll be gone. Actually, doctor, I have a lot of things in my head at the moment. I feel so good for the last few weeks and it's been the best time in my life. I just have so many thinking at the moment. I think like there are some atomic particles I'm doing some study and research, and that's the reason the professors are very jealous about me, and the students, oh, they are just some bullshit stupid people. they don't understand, or they're not in my level, doctor. So that's why they're just jealous about me. Then there is nothing wrong about me. If you just let me go, I'll be fine.
Okay, Sarah, I'm very much sorry about that, but you know that there's some ups and downs in our life, so everything will be fine, inshallah. And I hope I can help you. Not what I'm talking between you and me. Everything will be confidential. I give you the word, and no one will know about our conversation. Would you please tell more about your sleep, or about your exam, or current? What about your mood nowadays?
Oh, I feel so good, doctor. I'm feeling so good. I think like this is the best time in my life. I don't want to sleep. I don't want to like waste my time. I'm just doing a lot of activities. I have planned to go to the poker tonight. I've been seeing a lot of new people. So life is amazing.
Yes, you're right. Life is really amazing. So would you please tell me that do you hear some would you please tell me how much time do you sleep at night?
Oh, I'm not sleeping for the last 3 nights. I don't feel like sleeping because there's a lot of things I need to do. And if I don't write these things in my note, then I will just forget these things. And how I'm going to get the Nobel Prize on physics, I don't know. And then these counselors, the university professor, they will just clap for my achievement. That's all that I want now.
Okay, now may I ask you something that that may be weird for you? Would you please tell me, do you hear something that is not heard by someone?
No, what do you mean, doctor? You think I'm crazy? I'm not crazy,
No,
doctor.
Sorry, actually, I don't mean that. It is just a screening question, just to know more about your current problem. Do you feel that someone is going to harm you?
No, no one can harm me, but like they're just jealous about me. That's all.
Okay. Do you think that your thoughts are broadcasted, or someone is entering into your head and can take every information from you? Do you think like so?
No.
Do you think that life is not worth living, or
Oh no, why you would say that, doctor? I feel like life is so worth living because I've been getting all these good things in my life. And I've been doing research. I'm going to get the Nobel Prize. So life is good. And I don't want to end up losing my life. What are you saying?
okay, then so what do you taking any do you have any other do you have any weather preference?
No, but I like spring.
Okay. Do you have what about your home condition? What about your family members?
Oh, I just live alone, doctor. They don't understand me also. They just think I'm some crazy shits. But they will understand when I will get this Nobel Prize, and then they will again come. I know.
Yeah. Now, okay. Uh, do, do you think that you need some medical help now?
No, why I would need help? I'm fine.
Okay. I should not be judgmental to you. Just it's an screening question to you that is if you suppose there is a fire in this room, what will you do?
There is a fire in this room?
Not like that.
No,
Suppose.
just run away, doctor. I will just run away. I don't want to die because I have to do things for getting this Nobel Prize.
Then are you taking any medication for your for any problem? Like,
What problem? I don't have any problem, doctor.
any medicine or okay. Do you have any recent
Sorry?
so what is do you think that is a do you have tried before any harming yourself any
No, doctor. Why I would do that? You do understand that this is the best life that I'm having. I'm doing good. Just let me go, doctor. I'm fine. Just write me something and my counselor will be happy.
okay, can you tell me who am I
You are the doctor?
and what is the date today?
I just can't remember the date, doctor. Sorry.
Where are you now?
In the clinic.
Okay, thank you very much. Do you smoke?
I'm up. All right, Dr. Jayadul, your time is up, but I know that this is right. Now you did really good, being the first time you were doing a role play, and yeah, it is hard, and like keeping the nerve in these sort of cages, it's so hard. I know when we used to do it in the first time, we used to be like you, so it's totally fine. There is nothing wrong, but you did your best. Okay. And I'm sure that you will do a lot better in few months' time. So in this case was, what is the diagnosis, you know?
The manic disorder.
Yeah, that's right. Very good. So it was acute mania case. So these things comes in exam in many ways. Sometimes they give you like a history and then sometimes just history and diagnosis and DD. So it depends on what's coming in the exam. Now, when you are doing a mania case, it becomes so hard in the exam because the role player will be a lot more disturbing than what I was. So just think that the level of disturb that you will be having in this particular case. So this patient will run around the room, will stand up multiple times, and will be very loud, talkative. You will not get even like the first 1 or 2 minutes, she will just talk. Let her talk.
Okay.
Eventually, she needs to stop. She can't talk for 8 minutes. So let her talk, like finish, like let her to finish what she actually wants to say to you. And then you start your conversation. Okay, you just say that, well, I just try to listen to her, what she's saying initially, and you will understand that what's the case immediately. And one by one, you go into the case. Now, the initial starting was good. Couple of things we need to ask when we know that this is a diagnosis case, because we need to diagnose this case, and diagnosis of mania needs some criteria. So we haven't discussed this case so far, and that's pretty normal that you will not ask it. Now let's discuss that what is the criteria for mania. So to diagnose someone with mania, you need at least 4 symptoms or at least 5 symptoms out of these 8. And the duration of the symptom should be at least a week for mania and for 4 days for hypomania. So what are those? The most important one is having an elevated or euphoric mood, and then increased energy and activity. I'm going to just mute you for the moment. And reduced need for sleep. So they will have not insomnia, they just don't feel like sleeping. And very important finding is delusion of grandiosity. So they think that they have some special power or special abilities. And that should be given. If MSE is a presentation, you have to say that. Then also there is disinhabited behavior or impulsive behavior. Very important. I gave you some of these during my conversation. One of them is increased sexual drive, increased spending, like gambling, as I said, I'm going to poker tonight. That was actually this increased spending, meeting new people, having lots of sexual intercourse with unknown people. So these are all positive in mania patient. Increased subjective speed of thought. So that's mainly like very racing of the thought, rapid pressure speech they are talking about, being more talkative, speaking loudly. Increased distractibility. That means patient will have a lot of goal-directed activities and inability to focus on a special thing or focus on a specific thing. And they will not be able to complete tasks. They will just move or jump from one topic to another and one idea to another idea. And enhanced perceptual experience, like they will feel everything is good around them. Sounds are harmonious, colors are very good. So everything becomes so amazing around them. All right, so these are the features that you want to rule out. That means in your history, you need to ask a little bit more questions when diagnosis is a task, which means we have a format of asking mood. So you ask that, how is your mood? I say, oh, I feel so good. I feel so better at the moment. So at that time, you also need to find out that is this a patient having bipolar disorder or not? Then what you need to ask that anytime did you feel so low or very low or any previous history of having depression? If you get that, then you know that this patient is a bipolar disorder patient, not just a mania. So that's one question we always ask to a manic patient. And then you ask about sleep. You will find out patient does not need sleep. Then also patient can say that I feel so energetic. So you can say, how is your energy these days? Okay, you can also ask that one of the other thing that like are you spending a lot of money these days? Okay, and do you feel like going out and meeting new people? So those are some of the questions we need to ask to the patient. Apart from that, patient will give you most of the finding. So one question is mood. One question is increased energy. You can also ask, do you feel like involving in a lot of activities? That's one question. Do you feel like having a decreased need for sleep? You can find this out also. And do you think you have some special abilities that you can ask? Do you think that you want to spend a lot of money? Do you think like you are meeting new people and engaging in sexual intercourse or do you have increased sexual drive these days? You can ask these questions frankly, that's fine. Okay, so that's some of the questions you would try to find out from your history. Just add this in the typical psychosocial format that we have taught you. Other than that, other questions are all like previous. Nothing has been changed, but you just need to add this question because this is a diagnosis case, not just MSE presentation. All right, so that will be only thing in here. And the diagnosis in here is obviously mania. The differential diagnosis can be, you can say that it's a drug-induced psychosis. You can say substance abuse. You can say schizophrenia, okay, bipolar disorder, hypomania. Even you can say schizoaffective disorder. Any of those differential diagnoses you can ask here. All right. Any question, guys? We will discuss these cases with more elaboration in the psychiatry classes. So it's just a little bit of diagnosis differential that I have discussed today, but we'll go in detail about mania and everything later on. Yes, you have to explain the diagnosis to the patient. Now, mania does not have any specific definition in here. So you just can say that, well, you can say, thank you so much for all the information that you have given to me, Sarah. I really appreciate that. Now, according to the history that you have given, I am thinking most likely you are having a condition known as acute mania. Do you know what it is? No, doctor. Well, it's a condition in which you have your mood becomes very elated you start to feel everything really good. You have increased energy and lack of sleep. Now, this is a condition in which you also tends to lose touch with the reality. And that's why I need you to admit to the hospital to help you to get through a normal life again. So mania does not have any specific definition. You just use the specific feature to explain these things to the patient. So say that mania is a mental condition in which patients feel excessively good, or patient has excessively good mood. They have decreased need for sleeping, and they also have increased goal-directed activities and increased thoughts or racing of their thoughts. But this is not which is normal for them. And it becomes so excessive in a way that sometimes they tend to lose touch with their reality. And that's why it is a psychiatric emergency. And I need to admit you to the hospital to help you and to involve a psychiatrist to help you to go through this condition at the moment. Please don't worry, you are in a safe hand. And then you can give your differential diagnosis. You always say sorry, even if it's a crazy patient. Actually, you don't say that you are crazy. You always say, I'm really sorry that you feel that way. John, there is nothing you need to worry about at the moment. There are lots of medications and support available for you. You are not insane. You are not crazy. You are having a condition, and that has a meaning. And a lot of patient has similar condition like you. So you just, like, you know that this patient is, maybe he is insane at the moment, but that's a medical condition. And no patient is crazy. No patient is insane. That patient has a condition, and that's only thing you need to talk to them. You never ever say you're having, or you're being insane, you're being crazy. You just reassure them in a way that they don't feel judgmental. They don't feel like, well, my doctor is saying I'm insane, so I'm insane actually. So your response to this kind of question will be tricky. You just say in a way that sounds good and meaningful rather than hurting the patient. Even if it's a schizophrenic patient, they understand you, right? So always you need to use your sense to show them that, well, that's not something which is very unusual. All good, guys? Any question? All right, guys. So we'll do another case and then we'll stop it tonight. So anyone who wants to do a role play? Let me see that if there was someone else initially, if they want to do it. There was Rihan and then Jody. Yeah, Riham, so you can try. Sorry, Jody, we will not be able to do it today, but obviously just when we do the next role play, just say that you were the first, all right? And we can start from you. It's fine. So you will be the first one in the cardiology role play. I will unmute you, Riham. Can you hear me? Riham, can you hear me? I can't hear you. Your audio is not working. Now it's working. Can you say something?
No. Yep. Okay.
Yeah. Okay.
So
Good.
can I try?
Yeah. So I'm going to give you the case. Same like before, 7 minutes, 30 seconds and 1 minute outside. So that's your case. And your 1 minute is started. All right, so we can start.
Hello, David. This is Riham, one of the doctors here.
God is wonderful, doctor. He has planned for everyone. He's wonderful.
Okay, David. So I just need to ask you a few questions. Is that okay with you?
Yeah, you can ask anything.
Okay, so let me assure you that everything we are going to talk is confidential unless I'm concerned about your safety or other people's safety. So
There's nothing to worry about it, doctor. I am fine. God is saving me to save this world from harm. I'm not going to harm anyone, doctor.
Okay, so can you please tell me more about that? So like do you hear things from God, or can you tell me more about that?
Yeah, I can hear him, and he's saying me to do good to this world so that the poverty is gone and the righteous people get all the important things that they need for their life. So I'm going to save the world, and I am the messenger, doctor.
Okay. So is there any like commanding, like
No, he is not
any
commanding
orders?
it, saying things to save the world.
Okay. So can you feel things that people can't?
No, doctor.
Okay. Do you see things that people can't?
No, I can't say anything.
Okay. Do you hear any other voices apart from like God?
No.
Okay. So I just need to like just as screening questions. Do you feel that someone is spying on you?
No, they don't spy on me, but I know that people are jealous of me because I am the messenger of God.
Okay. Do you feel that you have special power?
Yeah, I am the messenger of God. I have some power to save this world.
Okay. So do you feel that that someone is spying on you?
No.
Okay, okay. Do you feel that someone is trying to insert some thoughts inside your mind,
No,
or steal some thoughts?
no,
Okay. Do you feel that your thoughts are broadcasted?
no,
Okay, okay. So, do you feel guilty of anything?
no, I'm not guilty about anything, doctor, but I need to save this world.
Okay, okay. So, can you please tell me more about saving the world? What will you do?
I would do some things to help the people.
Okay,
I
okay,
don't have any plan now, but I'm sure God will help me.
okay, okay. So, how about your mood these days? How would you assess your mood?
Okay, I'm
It's
fine.
okay? Fine, okay. And how about your sleeping?
Yeah, it's okay.
Okay, so I just need to ask you, if there is a fire, just a screening question, what will you do?
Nothing. Fire can't touch me, doctor. I'm the messenger.
Okay, okay, okay. So can you tell me what's the date today?
Date? I think it's something in February, maybe 2nd February.
Okay, yeah, okay. So and who am I?
You are the doctor
Okay, and where are we now?
in a hospital.
Okay, okay, okay. So can you tell me, I can see from the notes that you have a history of schizophrenia when you were 18. So are you taking any medications for it now, or are you
No,
do you have
they gave me some medication like when I was
okay,
18. I don't
okay.
even remember, but I ran out of it, and then I was feeling fine, so I did not take it.
So did you stop take it now?
Yeah, yeah. I don't need any medication. I'm fine.
Okay, do you feel that you are fine? Okay, okay. So okay. So do you smoke, David?
Sometimes, yeah.
Okay. How about alcohol?
No,
Okay. Any illicit drugs?
no,
Okay. Are you on any medications?
no medications, doctor. But as I say, that sometimes I love to have some pots or marijuana. That's all I use. I usually use.
Okay. When did you start having marijuana?
It's a long time, since I was 15, I guess.
Okay, okay. And how often do you use it?
Mostly every day.
Okay, okay. So I just need to ask you about, do you feel that life is worth living?
Yeah, yeah. Obviously, I'm the messenger of God. If I'm not living, then how am I going to save the world, doctor?
Okay, okay. Any like sometimes when people are so stressed, or they might have some thoughts of harming themselves or other people. Do you have any ideas of that?
No, I'm not stressed, so I don't feel anything like that.
Okay, okay. So any family history of like mental illness, or family history of mental illness?
I'm not sure about that.
Okay, okay. So can you tell me about your home situation? With whom do you live?
I don't live anywhere. I live in the street. I'm just at the mercy of wherever he takes me. I just go.
Okay, okay. So you don't have any support.
I don't need any support when I'm the messenger, doctor.
Okay. Any financial issues?
No,
Okay, okay. So okay. Do you still like meet up your friends, or
I don't have any friends. I just need to go to the people. That's all.
okay, okay. So thank you for your information, David. Um, so actually, most probably the reason of your symptoms, it could be related to a relapse of the schizophrenia that you have. as you were diagnosed with schizophrenia and you don't have to take your medication. So it could be relapse of your condition as you are some, and it could be related to marijuana that you are taking. And actually, for me now, I need to admit you in the hospital as like you appear to be a risk at yourself. So you need to be admission, and the mental health team will come and have a look on you, and they will give you some medications.
I'm up, doctor. Thank you.
Okay.
Thank you, Dr. Riham. You did nice in your history. I know the task 2 is still tricky, but yeah, the psychosocial history was good. But don't take too much history because it's about like 7 minutes you took the history. You will never ever get that much time in the exam. 6 minutes is highest. So cut short. If you think that I can't remember any question, that means you asked everything. You don't need to find any more questions. So at the end, you thought that, well, there are maybe some questions I did not ask. So don't think. When you are running out of questions, it means that you did well. Okay.
Okay.
Now, I think like one of the thing is like initially the approach was good. You can say something else, like some more reassurance you can give to this patient so that he opens up with you, rather than giving just the confidentiality statement. That's always I encourage everyone to do that. That's how you get different from others. You can use your own sentence, but that's fine. But use a little bit of more reassuring things. Try to talk to the patient, be friendly with the patient. That's the starting should be.
Okay. Okay.
And then you got to know from the patients that, well, he's talking about God is wonderful. You can ask the duration, how long you are feeling this way. And that way you know the duration also. That's always a good idea to ask. Okay. And you ask, I think, almost every questions, nothing to add in here, apart from, I think, like you asked all the delusion questions, hallucination questions, everything you asked. So history was pretty good. And when you come to the cause of the symptoms with the risk assessment, now risk assessment doesn't mean that you have to do the management in here. You started talking about management. When management is not a task, don't bother with that because that's not going to give you any mark. If you talk about the risk assessment, like if this patient is a high risk or low risk, you just say that, and why do you feel like that? That should be more appropriate. So there are lots of things as a feedback given in here. You guys can give it a read later on in the software. So there's a very good explanation how the candidate did in the exam. See that I'm very happy that you are feeling elated, and it's a very good feeling to be positive as you are. The only problem with it that sometimes with these intense joyous feelings, it can make you get detached from the touch of reality. And sometimes these things can become quite confusing and overwhelming for you. According to your history, I am suspecting that the feeling that you are having at the moment, that you are a messenger of God and you can hear God's voices, most likely it's due to a relapse of schizophrenia. It means that you had a diagnosis of schizophrenia when you were 18, you were giving some medication at that time, and then you felt fine and you stopped taking that medication. And that's most likely the reason that now you are having these symptoms back again. The symptoms that I am worried about at the moment is that you can hear God. And normally, when a person can hear God in a way that you are feeling, we call it as an auditory hallucination, which is a part of your diagnosis. When you have this kind of symptoms, you are at risk for yourself and others. And that's the reason I need you to get admitted in the hospital. You'll be seen by a doctor who is very good with dealing with your symptoms, and then he will manage you appropriately. Now, you are also risk to yourself and others, and I'm thinking, and in my view, you are in a high risk category because You are having this active hallucination and delusion that you believe that everyone is jealous about you because you are the messenger of God. On the top of that, you are having non-compliance with your medication. You are using marijuana, which can provoke these symptoms. And also, you don't have any active support. You don't have any consistent accommodation. All of this letting me to think that you're in a high risk. And that's why you need to stay with us in the hospital for a while until you become more stable. So in a very good way, you just say these things. Now it becomes really weird in the exam to give a diagnosis of schizophrenia to a patient. But don't feel weird, just say these things. And they know that this is weird, but you just need to talk through it and just explain the diagnosis a little bit and say that why this patient is high risk. Yes, delusion of grandiosity is also there. If MSE presentation was there was auditory hallucination, there was delusion of grandiosity and delusion of jealousy or paranoid delusion. No, you can't keep a wristwatch, no watch during exam. You can only have your stethoscope in the exam. That's all. In the face-to-face, especially, that you can have your stethoscope. In online exam, you can have a pen and paper in front and a bottle of water without any writing. Yes, Dr. Manas, you have to ask about the previous schizophrenia when it was diagnosed. And was he on medication? Why did he stop medication? Sexual history, why? Dr. Javed, are you asking about this question? And Dr. Wang, sometimes you get a reminder if your task says that history for 6 minutes, then you will get a reminder in 6 minute time. If task doesn't have any timing written, then you will not get any timer. Sexual history will not be very important in here. Not very important, okay? Now, I was saying at first that we have a criteria to say that how risky this patient is. Now, you need to say the scoring in the exam. You just say high or low risk, that's all. Now, these are the things puts a patient in high risk. Sex, male, gets 1 point. Age, less than 19, more than 45, 1 point. Depression or hopelessness gets 2 points. Previous suicidal attempt, 1 point. Excessive alcohol or drug use, 1 point. R is rational thinking loss, which is loss of insight, 2 points. S for separated without any, like separated divorced patient. O for organized or a serious attempt or a plan of suicide, that's 2. N for no social support, that's 1. And S for a stated future intention of suicide, that's 2 points. Okay, these are the things puts a patient in a high risk category. But just for your own understanding, keep it in the exam, like if a patient having active suicidal or homicidal thought, having active hallucination delusion, having loss of insight, loss of judgment, having substance abuse history, having active suicidal plan or thought with access to the weapon or any others abusing, and loss of support, these are the patient who will be in high risk category. Okay. All right, so that's pretty much everything about MSE role play tonight. I hope you guys enjoyed the session. A lot of things to learn from these sort of role play sessions. I hope that was helpful for you. And Dr. Javed, so resources for AMC clinical, there are not much resource about it because you get to learn the cases And you just need a good note for that. And you need to do the role play every day. That's how you improve your approach towards the patient. Now, for AMC clinical, yes, if you just follow our notes, that's more than enough. There is nothing else you need. And if there is anything, we will go through that during the class, that go through this part, go through this book. We will go through along the way. For learning how to talk in a non-medical jargon, you can always use some of the website, like you can use Patient Info. Patient Info is a very good way of learning how to discuss things to a patient. And also you can use John Muttag Patient Education. That's also has some of the cases that's written in a non-medical jargon. So you need to just learn the way of explaining things to a patient. Okay, that's the important part. And the more you do role play, the more you hear other people doing role play, you will learn it. It's a kind of active and passive learning. And the more you do it, more you learn and more you get improved. Dr. Arifa, for sexual promiscuity in a mania patient, it's a good idea. If you have some time, you can say, Sarah, I'm going to ask you some sensitive questions. Do you think for the last few weeks during this feeling good, are you also having a feeling to meeting new people or engaging in some unsafe sexual practice? You can ask in a way that doesn't feel like judgmental to a patient. Or do you think that you are having increased sexual drive these days? Just that this question is fine if you are running out of time. All good. I haven't actually looked into the Facebook at all. For the role play session, guys, always come to the Zoom sessions. And you already know the Zoom ID and everything. So try to join the Zoom session rather than being in the Facebook. And I think that should be also a good idea to, at least it's a good idea that I get to learn your name, and then I will also feel involved with your learning. No need to ask delusion of guilt in mania case. That's a good thing, Dr. Namia, that depending on the case, you can always rule out some of the delusion question. Like a patient who is having schizophrenia, you don't need to ask delusion of guilt. You don't need to ask like, no, just delusion of guilt you can rule out. And in case of mania, same delusion of guilt you don't need to ask. For a patient who is having depression, like you don't need to ask, do you think you have a special power? So depending on the case, you can rule out some of the unrelated or irrelevant questions. Yeah, alcohol drug history is very important. Always, when your diagnosis and DD is a case, your DD is always a substance abuse. Always, anything you can put, like as a differential diagnosis, you can put substance abuse there. So always ask the alcohol, recreational drug abuse things. And I can see, Dr. Taiba, you wanted to perform a case, but you were in Facebook. We can't do role play on Facebook, so you have to come on Zoom session for that. And Dr. Janardhan, you can't finish MSE in 1 minute. You need 2 minutes to do it appropriately. So cut short your history for that. So the next lecture, I think I have given a schedule in the Facebook group, Dr. Javed. Have a look on that. I keep forgetting that. So the next class is on 5th of February. So we will do cardiology lecture, the theory class 1 on 5th of February. All good. So I guess that we can finish our lecture tonight. if you guys still want to know a little bit more about the course, there are a lot of information already given in the Facebook group, First Aid AMC Clinical. You can always go through that. And also in the announcement section or featured section of the group, you can always get the updated version of the course detail. So if you just click on featured version of the Facebook group, you can always get our course detail. Okay. Still, if you are unsure what to ask, just ask us in the email or inbox me. That should be fine. Thank you all. Have a good night. Bye.